It is not surprising Patrick has some respiratory distress. An obvious contributor to this is his COPD, which he has most likely been suffering from for quite some time, as his lower limbs are swollen. Patrick was a smoker for 40 years, also exacerbating and potentially causing his COPD. Another comorbidity he faces is the worsening of his left-sided heart failure. This condition causes the heart to gradually lose its ability to contract, which decreases the amount of blood circulating the body. Decreasing contractility causes blood to back up inside arteries, causing further distress as fluid begins to pool inside the alveoli of the lungs, causing difficulty breathing and dyspnea. The functionality of Patrick's lungs and alveoli is already compromised due to his COPD, therefore worsening his presenting symptoms. Patrick presented with a tachycardic heart rate of 155 beats per minute. Similarly to before, his two major health concerns of COPD and left-sided heart failure have complications relative to each other. Left-sided heart failure particularly affects oxygenated blood circulation, as the left side receives oxygen-rich blood from the lungs and pumps it throughout the body. A decrease in perfusion would result in hypoxia of cells. COPD makes breathing increasingly difficult as alveoli in the lungs that perform vital gas exchange are damaged, also leading to hypoxia. Due to the body continuously lacking in oxygen, the sympathetic nervous system activates its fight or flight compensatory mechanisms and increases the heart rate in an attempt to maintain perfusion. Heart rate also increases as there is decreased stroke volume and hypoxemia due to left-sided heart failure, as the heart is unable to fully contract.
Tobacco smoking is the single largest risk factor for chronic obstructive pulmonary disease. As a smoker of 40 years, it can be assumed this was the most significant causative agent in Patrick's diagnosis of COPD. Long-term inflammation of the airways, alveoli, and microvasculature originates from exposure to tobacco smoke, environmental factors, or air pollutants. This then causes irreversible limitation of airflow and impaired gas exchange that characterize the diseases that fall under COPD. Remodeling or narrowing of the airways and mucus hypersecretion in response to inflammation explain why Patrick is experiencing dyspnea and persistent coughing, respectively. The etiology of Patrick's left-sided heart failure can be attributed to a myocardial infarction 10 years ago. Uncontrolled dyslipidemia causes atherosclerosis, which will eventually result in a myocardial infarction. After such significant cardiac event, the heart becomes scarred or weak, and as a result cannot contract adequately. Furthermore, sustained hypertension places stress on the heart, and the pumping of blood around the body becomes more difficult. To cope with this extra effort, the heart becomes thicker or hypertrophied, and once more is unable to contract adequately. In left-sided heart failure, the left side of the heart must work harder to pump oxygenated blood from the pulmonary circulation through the left atrium and ventricle onto the rest of the body because of the impaired contractility of the left ventricle. Blood enters the ventricle during diastole and is then ejected into the aorta during systole. If the ventricle cannot generate enough contraction force, then the stroke volume and subsequently cardiac output is reduced. This results in an increase in end-systole volume, in turn causing a backup of blood into the lungs, where pulmonary edema and pulmonary hypertension then ensue. The relationship between left-sided heart failure and COPD is bidirectional. One can exacerbate the other. Pulmonary edema, secondary to left-sided heart failure, causes impaired gas exchange, which leads to breathing difficulties that can exacerbate COPD. Conversely, COPD, by definition, decreases blood oxygenation, which activates the sympathetic nervous system. Catecholamines are then released to increase heart rate in compensation, thus placing more stress on the already failing left ventricle. They may have developed independently of one another, but in coexistence they worsen Patrick's condition. Low blood oxygenation that occurs secondary to the impaired gas exchange or airflow obstruction that is characteristic of COPD causes Patrick's pulmonary arteries to constrict and subsequently pulmonary hypertension, which is the leading cause of cor pulmonale or right-sided heart failure. The increase in pressure makes it harder for his right ventricle to pump blood to the lungs via the pulmonary artery. Because the left side is responsible for pumping blood to the entire body, it requires a higher pressure in contrast to the usually low-pressure pulmonary system that is supplied from the right side. Therefore, the increased pressure places a strain on the right ventricle, once more causing enlargement and stretching of the heart and subsequent failure of the right side.
Patrick's blood test results reveal his levels are all outside of their normal range. To begin, hyponatremia and hyperkalemia are a result of heart failure. Fluid retention is a common symptom from heart failure and explains this elevated sodium levels. Hyperkalemia is an effect of the ACEI drugs used in heart failure patients, as they decrease aldosterone, causing potassium retention as aldosterone controls potassium secretion. Anemia or low hemoglobin levels are also respective of his heart failure, as anemia is a common factor in the initial diagnosis. Calcium entry and sensitivity are both reduced in heart failure, and as calcium plays a part in muscle contraction, the heart's functionality is weakened further. The combination of high LDL, low HDL levels, and high triglycerides is a common indicator for heart failure and heart disease, along with his larger body weight and waist circumference contributing to his concerning cholesterol levels. Patrick's glucose levels were slightly elevated, but asymptomatic of any physical or neurological dysfunction at this stage. Neurological function can also be impacted by hyponatremia, with symptoms starting with increased thirst and progressing to confusion, muscle spasms, and twitching due to brain cell shrinkage. Hypercalcemia impairs neurological function as calcium plays a big role in strengthening cardiac muscle and cell death, with some symptoms including seizures, dysphagia, and tingling. Neurological deficits can also be majorly caused by hypoxia on the brain as a result of Patrick's COPD and can cause cell death and brain damage.
Brain natriuretic peptide is a hormone made by the heart that indicates whether or not it's working properly. In a healthy person, circulating BNP levels would be low. However, when the heart is placed under extreme stress for long periods of time, as in heart failure, then the level of BNP in the blood will be high. The reference ranges are employed in the case of patients who present with dyspnea. Natriuretic peptides are synthesized and released by ventricular musculature in response to ventricular stress, particularly during states of volume overload and stress. The role of the hormone is to assist the heart in dealing with this stress through vasodilation, natriuresis, and diuresis. With consideration to Patrick's diagnosis of left-sided heart failure, the musculature would be hypertrophied, dilated, and stretched after compensating for a dysfunctional left ventricle for some time. As such, his expected BNP test result would be above 400 picograms per milliliter.